Assalamu alaikum. This is the second part of the lectures that entitled Acute Gastroenteritis in Pediatric. In the previous lecture, we learned how to diagnose a patient with acute gastroenteritis and how to determine or assess the degree of dehydration. In this lecture, we're going to discuss the lines of management of a patient presented to us with acute diarrhea. Management of acute gastroenteritis. After knowing that most infectious causes of diarrhea in pediatric age group are self-limited, so management of viral and most of the bacterial causes of acute gastroenteritis is mainly supportive. That means we should correct any degree of dehydration and we should replace the ongoing fluid and electrolyte deficit. We have to manage any secondary complication that result from mucosal injury. Antibiotic is not routinely used in pediatric age group. We have only certain indications of using antibiotic in a case of gastroenteritis. It's used only for children with bloody diarrhea. Mostly that's result from Shigella. Also in a case that we suspect cholera with severe dehydration, any serious non-intestinal infection like if the patient developing pneumonia, meningitis and others, we use antiprotozoal drug. It can be very effective for diarrhea in children, especially for giardia or Entamoeba histolytica. Antibiotic used for all severely malnourished children, they should receive broad spectrum antibiotic. Also for a toxic febrile child and for those whose age less than 3 months. Treatment of acute gastroenteritis is including continuous feeding, addition of a fluid, and zinc. We start initially with correct any degree of dehydration. Firstly, we have to assess the degree of dehydration in order to treat any existing dehydration. The degree of dehydration, it will lead us to the urgency of the situation and the volume of the fluid that is required for rehydration. According to the signs and symptoms of the patient, we divide the patient, as we already said, into three groups. It's either having no dehydration, or some dehydration, or severe dehydration. Patient who is having no dehydration usually follow plan A for treatment. Treatment here is directed to prevent the development of dehydration, which include giving an extra fluid and salt to replace the ongoing diarrheal loss. The mother in this situation is instructed to give an extra amount of suitable fluids. The amount of fluid given by the mother should be as much as the child wants until the diarrhea stops. As a rule, the child should receive an oral rehydration solution at least after each bowel motion in amount about quarter to one half large cup, which constitute about 50 to 100 cc for children whose age less than 2 years, while in children older than 2 years, they usually receive 100 to 200 cc of a fluid. Regarding feeding, patient should continue on his usual feeding to prevent malnutrition. Most children with watery diarrhea regain appetite when rehydration is corrected, while those patients with dysentery usually remain to be anorexic until the disease resolves. Continuous feeding during diarrhea, it will speed up the recovery of a normal intestinal mucosa. Breastfeeding should be continued with artificial feeding. If used, should be given with very careful attention for sterilization. During this process, it's very important to stress the information to the mother that she should not dilute the milk. The role of zinc in treatment of acute gastroenteritis is that it will decrease the duration and the severity of the diarrheal attack. It is important for the child's immune system and it will help the child to fight off a new episode of diarrhea in the following 2 to 3 months following recovery. Zinc also will improve the appetite and growth. So children whose age less than 6 months should receive about half tablet of zinc, which constitute about 10 milligram daily for about 2 weeks. While for older children, they should receive 1 tablet per day for about 2 weeks. The mother should be counseled that she should take the child to the hospital if any one of the following symptoms have been developed. If the child starts passing many watery stool, if he develops repeated vomiting, if he developed severe thirst, or if he rejected any food and fluid, if the child develops fever or blood in the stool, and lastly, if he didn't show any sign of improvement after 3 days. Patient with sign and symptom that categorize him into having some dehydration, we follow plan B for treatment. A child with some dehydration usually require an extra fluid and food. We have to treat the child firstly with ORS in a health facility. And then when all signs of dehydration disappear, then the child can be safely sent home with continuous treatment. Giving ORS in the clinic until the skin pinch is normal and the thirst is over, the child is calm. 4 hours of rehydration are usually necessary for achievement of that. The use of oral rehydration solution in a patient with some dehydration is follow the same guideline for patient with no sign of dehydration. The difference here is in the amount of the deficit. In patient with mild dehydration, we give 50 cc per kg, while in patient with moderate dehydration, the deficit will be 100 cc per kg, and it should be given within 4 hours. We also we have to replace each ongoing loss by giving an additional ORS. For each bowel motion, we add 10 cc per kg of ORS. Besides calculating the amount of deficit and maintenance, we have to replace the ongoing fluid loss. Patient with frequent bowel motion or diarrhea, he will lose about 10 cc per kg with each bowel motion. Beside that, a patient with continuous vomiting, he may lose up to 2 cc per kg for each vomiting attack. In addition to fluid, child with some dehydration needed food. So after we complete the first 4 hours of treatment with ORS, a breastfed child should continue on breastfeeding, while other children should receive their usual milk or food. Instruct also the mother about zinc supplementation. Start the first zinc supplement in the clinic, and after that, we should instruct the mother to complete 2 weeks of zinc. It should be given as soon as the child can eat and the child has successfully completed the first 4 hours of rehydration. The principle of oral rehydration therapy is based on the fact that intestinal absorption of sodium and other electrolytes it will be enhanced by active absorption of certain food molecules, such as glucose. This process of active absorption will continue to function normally even when the patient develops secretory diarrhea. So if the patient with secretory diarrhea drink any isotonic salt solution that does not containing a source of glucose, the sodium will not be absorbed. So this fluid will remain in the lumen of the GIT, which will add it later to the volume of the stool. In addition to the standard oral rehydration solution, we have a more effective lower osmolar ORS with a reduced concentration of sodium and glucose. The advantage of this lower osmolar ORS is that it is associated with less vomiting and it is associated with less amount of stool and a reduced need for intravenous fluid in comparison with the standard ORS. ORS have many advantages over IV therapy. The ORS is less expensive, it is available, and it is easily prepared by a family. It's given by normal oral route, and it has advantage of shorter time for correction of dehydration, 4 hour compared to 24-hour inpatient on IV therapy. Also, in ORS, we don't see the complication that may occur in IV therapy, like pain, thrombophlebitis, and so on. With ORS, we have high successful rate in about 95% of all cases of acute gastroenteritis, which has lessened the diarrhea-associated malnutrition. After rehydration is complete, then we shift the patient to maintenance therapy. Maintenance therapy consists of 100 cc of per kg per 24 hour of ORS. The patient should continue to receive this amount until the diarrhea stops. In addition to that, breastfeeding or formula feeding, they should be maintained and not delayed for more than 24 hours. ORS can be prepared in a simple way. The family should be follow the instruction that is written on the container. After dissolving in an appropriate amount of sterile water, it should be given by spoon or syringe and not by bottle in order to prevent vomiting. The mother should give it in a sips every few minutes according to the severity of diarrhea. All the amount that had been prepared should be consumed within 24 hours. In some patients, we cannot use ORS. There are some contraindications for using of oral rehydration solution. For example, patient with severe and persistent vomiting, since vomiting is not contraindication of using ORS, but if it is severe and persistent, then we have to use IV fluid. Also, if the patient have severe dehydration, that approaching to shock. If the patient have severe diarrhea, that means he had more than 10 cc per kg of bowel motion. If the patient is unable to have oral fluid, as in a case that the patient have loss of consciousness, because at this case there is a risk of aspiration. Also, if we already need an IV line for other purposes, for example, we need an IV medication, at this case we have to give an IV fluid. If we decide that the patient requires rehydration by using intravenous fluid therapy, then the first step is to decide whether the patient requires fluid boluses in order to restore the intravascular volume. For example, a child with mild dehydration usually does not usually require a fluid bolus. In contrast, a child with severe dehydration may require more than one fluid boluses. The usual fluid bolus fluid that's required is a normal saline. The dose is 20 cc per kg, running over 20 minutes. After the patient receives fluid boluses, then we have to calculate the 24-hour fluid need, which consists of the deficit plus the maintenance. Firstly, you have to determine the amount of deficits. Deficit is determined by multiplying the percentage of dehydration times the percentage of body weight. Patient with mild dehydration, which means 5% dehydrated, the deficit is equal to 50 cc per kg. Patient with moderate dehydration or 10% dehydration, the deficit will be 100 cc per kg. And lastly, patient with severe dehydration, 15% dehydrated, it means that the deficit is 150 cc per kg. Now, an example of how to calculating the deficit is a child whose weight is 7 kilograms and presented to you to the ER, and during examination you found a sign of mild dehydration. As we said, child with mild dehydration, it means that he lost 5% of body weight or the total fluids, which means that we have to multiply his weight by 50 cc. In our patient, it means that 7 multiplied by 50, which equal to 350 cc. The maintenance of the IV fluid is depend on the weight of the patient. The first 10 kilograms of the weight of the patient, the maintenance will be 100 cc per kg per day. The second 10 kilograms will be 50 cc per kg per day. After that, each additional kilograms will add it 20 cc per kg per day. For example, if you want to determine the amount of maintenance fluid for a child whose weight is 17 kilograms, first you multiply the first 10 kg of his weight by 100, and the second 7 kg it will be multiplied by 50. So in a result, the total amount of maintenance fluid for our patient, it will be 1350 cc per day. After we calculate the total amount of fluid that's required during 24 hours, then we divide this into two halves. The first half is given during the first 8 hours. The second half is given over the following 16 hours. During that time, each ongoing loss should be replaced according to the amount. For example, when a 6-month-old infant that presented to you with a history of acute gastroenteritis, and during examination you assess that he has signs of mild dehydration. His current body weight is 7 kilograms. Now you are required to determine the amount of fluid that the patient required, and how you are going to give this fluid during the next 24 hours. The amount of fluid that's required for this patient is equal to the maintenance plus deficit. The maintenance, as you already learned, that for the first 10 kilograms of the patient's weight, each kilogram will be multiplied by 100. So as our patient is 7 kilograms, 100 multiplied by 7, it will be 700 cc as maintenance fluid. For deficit, as we said that patient with mild dehydration, it means that he lost about 50 cc for each kilograms. So 50 cc multiplied by 7 kilograms, it will be 350 cc. So the total amount of fluid required during the next 24 hours, it will be equal to 700 plus 350, which will be in a total 1050 cc. The total amount of fluid then we divide it into two halves. The first half it will be given during the first 8 hours, and the second half it will be given over the next 16 hours. Probiotics are non-pathogenic live microorganisms that provide beneficial effect on the health of the host. During the last years, probiotics have entered the mainstream medical practice as it will decrease the severity and the duration of infectious gastroenteritis. The mechanism of action is not completely understood. However, it has been hypothesized that it will cause suppression of the growth or invasion by pathogenic bacteria, and that's why it will enhance the host protective immunity, and it will restore the beneficial the intestinal microflora. Antimotility agents, for example loperamide, are contraindicated in the treatment of acute gastroenteritis in children. That's because of their lack of benefit and increased risk of side effects. The most common side effects that encountered is ileus, drowsiness, and nausea. Antiemetics, for example, phenothiazine, are of little value and it is associated with a serious side effects. However, we have the ondansetron, which is the effective and less toxic antiemetic. It is used in an ambulatory setting in order to decrease need for intravenous fluid and hospitalization. However, most children do not require specific antiemetic therapy, and only that required is a careful oral rehydration therapy. Cadatril is an oral encephalinease inhibitor. It is used in the treatment of acute diarrhea. It will act by preventing the degradation of endogenous encaphalines. That's why it will reduce the hypersecretion of water and electrolyte into the intestinal lumen. Still, the experience with the use of this drug is limited, and for an average child, it may be unnecessary. Prevention of gastroenteritis. We have multiple measures that can be aid in preventing gastroenteritis. For example, improving case treatment and tracing the source. We have to encourage exclusive breastfeeding during the first 4 to 6 months of life with continuous breastfeeding up to 2 years of life. We have to improve complementary and feeding practice and water sanitary facilities. In addition to that, we have immunization against rotavirus and should encourage vitamin A supplementation.